We're on to chapter 20, vessels and circulation. And we've actually kind of talked about a few of these topics already, but we're going to get a little bit more in depth at this time. I always describe arteries as being muscular and veins as being flabby. The important thing is that there are three layers to arteries and veins, but it is the concentration of the various layers that make one muscular and the other flabby. So let's take a look at our cartoon picture here, where it talks about the structure of the blood vessel wall itself. We have indeed three layers or tunics, and we're going to start on the inside, the luminal side of this, and that is called the tunica intima. Our tunica intima also is known as tunica interna, and it is simple squamous epithelium that has a special name. It's called endothelium. Whenever you hear the word endothelium, you are in a blood vessel. You don't know whether it's an artery, a vein, or even capillaries, but you are always in a blood vessel when you hear the word endothelium. So realize it's simple squamous epithelium. It is just like endocardium. And so our red blood cells and plasma and all the stuff that's in our blood actually only see one type of cell as they make their way through the cardiovascular system. The simple squamous epithelium is there to provide a nice friction-free surface for our blood as it travels through this. Going in, because up here in our cartoon there's tunica intima, going from the internal out, the next layer is called the tunica media, and that is a smooth muscle layer. It is circular. It encircles the luminal aspect of this. It is under sympathetic innervation only. Remember, the vascular tree only has one branch of the ANS that actually activate it or are in control of it, and that's the sympathetic branch. And so what we have to realize when you get vasoconstriction or vasodilation, it has everything to do with sympathetic output, or whenever we're not under any sort of duress, rest, digest, sympathetic tone to your blood vessels. And so if you want your blood vessels to vasodilate, what will happen to the sympathetic output to that vascular area? Will it increase or decrease? It decreases, because when we are under duress, our sympathetic output increases, correct? And we will have, this happens all the time when I'm up here, and we will have, when we're under duress, we'll have vasoconstriction to certain tissue beds, but we will have vasodilation to others. But at this time, I want you just to think about sympathetic activity will cause vasoconstriction when it's increased and vasodilation when it's decreased in a general situation. So that's the tunica media. Take a look at the cartoon of the artery on the left and then the vein on the right and see the big difference in tunica media. The vein has some smooth muscle, but it doesn't have much. The tunica media of the artery is indeed quite thick. And that's also something I want to point out before we get to the tunica externa. Take a look at the lumen, the size of the lumen of an artery versus the size of the lumen of a typical vein that's going to be accompanying that artery. Which one has a larger lumen? The vein. And that's what's interesting. The vein has a larger lumen, but it has less muscle in the wall. And that's why I call them flabby, because they are easy to collapse. And that is something that you actually found when you were working on your heart dissections. Anything of venous nature was a more collapsible structure. Of arterial nature had a tendency to keep the lumen open and patent. So veins are easy to collapse. Another reason why I say they're a bit flabby. The tunica externa, it's nice that they have these names. These names are not too hard to remember, is also referred to often as adventitia because it's not serosa. Remember, serosa is simple squamous epithelium. The tunica externa is not serosa. It's more adventitia, which means we have a lot of areolar CT associated with this. Remember, areolar CT is that Cottony CT that itself can be very vascular. It's important because this tunica externa is going to anchor the blood vessels in their area. helps to keep them in place. The interesting thing about this tunica externa is that it is thicker in veins than it is in arteries. And when we go up to the cartoon for just a moment and take a look at that, indeed, you can see the tunica externa, the external aspect of the blood vessel, has some substance to it in the artery, but when you take a look at the vein, it actually is thicker and even has vessels in it. The interesting thing is that this is supposed to help anchor our blood vessels in an area, but isn't it interesting when you go in for a venipuncture, which means you're going to get blood drawn, and blood is drawn from your veins, not your arteries, you will actually sometimes have difficulty obtaining blood because your veins will roll. And so this is more common in certain people, and certain age groups have a lot more difficulty with this rolling of the vessels. And the age group that has more difficulty is the older population, correct? Lots of things start to wither away as we age, but you know, that's just the facts of life. So that tunica externa of those veins sometimes is not doing a very good job of keeping them in place. We'll get to the capillaries in just a moment, but realize that the capillaries are just going to be tunica intima because they're going to be endothelium with a basement membrane, and that is where our nutrient and waste exchange will actually occur. Lumen, again, is the inside of a blood vessel for us because we're on the vascular tree right now. Our notes say space where the blood flows, and just based on this histology picture, it's easy to pick out the artery and to pick out the vein. Here is our artery, and here is our vein. Larger lumen, and you can't tell here, for some darn reason this doesn't have the vein collapse, but in most cases the veins would be pretty well collapsed. You'd still see some red dots in that, which obviously are blood. So red blood cells in those, so which is consistent with where blood should be in the vascular tree. Let's take a look at the arterial system. Arteries always take blood away from the heart. We have two main arteries, and then we have the smallest of these arterial structures, arterioles, and we'll talk about in just a moment. The main arteries that we name and encounter are going to be our elastic arteries and our muscular arteries. Elastic arteries have indeed quite thick walls and have a very large diameter and lumen and are close to the heart. So the first one that we will encounter will be the aorta. It is a beautiful example of an elastic artery. We call these elastic, and we'll add more to this list in just a moment. We call these guys elastic arteries because they have a lot of elastic CT throughout all of their tunics. So they are very elasticized. So elastic CT is going to be heaviest in the tunica media of these areas, these blood vessels. They have it in interna and externa, but it's very prominent in tunica media. Elastic CT is in tissue because we like what it does for us. It allows for tissues to be stretched, but beyond stretched, more importantly, it allows them to recoil or come back. So it's the recoil feature that is actually very important, which also gives us that conducting ability. So we have that ability to recoil, and this will help the pressures to remain constant in the arterial tree. And we're going to say relatively constant. Some of the other arteries that are called elastic arteries and conducting arteries are the pulmonary trunk, the brachiocephalic, the subclavian, the common carotid, and common iliacs. You've heard of iliac before. Where did we talk about iliac in the past? It's with our hip bone, right? So the common iliac is going to be right in that area. So it's at the end or the terminus of the aorta as it branches into the major blood vessels, which are going to go off to your extremities or lower extremities, the common iliacs. All of these vessels have a lot of elasticity in their layers. And so that means that when we have our bolus of blood, or I like to say bush, when we have our bush of blood into the vessel, they will almost expand like when you're trying to blow up a balloon. Remember when you blow up a balloon that has this area that actually fills up first with the air? So these guys will fill up in a very localized area with the volume of blood that we're forcing out, and then we'll have the recoil, and that pushes the blood along after the bolus has been delivered. So that's what allows us to have a more continuous flow of blood in our vascular tree, and it's conducting blood away from the heart. So that's a very important component of these vessels. These elastic arteries will then make contact and give rise to muscular arteries. And these indeed are medium size, so we're going from a large size now to a more medium size. And we'll find a lot of smooth muscle in their tunica media, then we will find elastic fibers. So elastic fibers are not a big component of their makeup in our muscular arteries. We call them distributing arteries because they are going to control the flow of blood to the organs by which they are next to. So it controls local blood flow to organs nearby. They're muscular, which means they have the beautiful ability to vasoconstrict when we want to decrease blood flow to an organ, or vasodilate when we want to increase blood flow to an organ. And so when we are under sympathetic fight-flight and you are a renal artery, are you going to vasoconstrict or are you going to vasodilate? You will vasoconstrict because you don't really care about your kidneys until you know you're going to be living long enough to pee again. So vasoconstriction is going to be the phenomenon that these muscular arteries are going to employ to decrease blood flow to the kidneys, and we're going to learn when we go under with our kidney anatomy and physiology. The kidneys also will restrict their own blood flow so that we can keep the volume of blood in the circulatory tree so that it can be sent to the organs that are saving your life, such as the skeletal muscles of your legs. These muscular arteries are named. So are the elastic arteries. We just named a few of them. And you have to realize they're going to continue to get smaller and smaller and smaller till they get so small that we really can't see the next branch in the system without some sort of magnification, even if it's a handheld magnifier. And the muscular arteries are indeed going to give rise to the smallest of the arterial tree, which are arterioles. What's interesting are our arterioles still have the same three tunics. It's just that they're just so much smaller. And they're designed to stay open or patent. They're designed, even though they're very small in diameter, they're designed to have an open or patent lumen. Because they're so small and you cannot see them with the eye, ordinarily they are not named. Capillaries are indeed the smallest of all of our blood vessels. It's just our tunica intima on a basement membrane. There are three types of capillaries that I would like you to know. We have the continuous capillary, which is the most abundant type of capillary we have. We have the fenestrated capillary, which means pores or windows. And then we have sinusoidal capillaries, which are actually kind of discontinuous and actually look very holy and would allow a lot of things through, which is actually what they are designed for. One of the things about capillaries is they are all over you. They are just like your arteries and veins are all over you. Capillaries are all over you. And when we get down to these little small blood vessels, the arterioles giving rise to the capillaries, we call the capillaries they give rise to a capillary bed because it is a vast vascular supply. If you were to take a look at a capillary bed and remove all the tissue surrounding a capillary bed, you'd have this like red blush being exhibited because they actually go through and they just weave themselves through all of the interstitial areas that they can in various tissues and organs. There are some organs that are not very well vascularized, and organs or tissues, and so we've actually already talked about them. Let's do tissues because we've talked more about tissues than specific organs per se. What tissues do we have that do not have rich capillary supply to them? Cartilage, because the things that don't have a rich capillary supply don't heal well, correct? So that's why it's really easy to actually figure out where we don't have a lot of capillaries. So types of capillaries almost everywhere, except cartilage. And it doesn't matter what type of cartilage you're talking about, hyaline cartilage, fibrocartilage, elastic cartilage, okay? What other tissue or organ do we not have very well vascularized, so therefore it doesn't heal well when injured? Ligaments and tendons, right? And there's an organ that's a special sense organ that we actually talked about that has a layer that is also not very well vascularized. You guys remember what that would be? The sclera. So it's interesting, and remember, these things are not well vascularized, don't have rich capillary beds, so they have to get their nutrients from adjacent areas, which are typically very vascular. Looking at our definition of continuous capillaries, most common again, endothelium, which is what we call any lining of a blood vessel, is joined by tight junctions. Remember, tight junctions are like snaps on a shirt. So, and they're close together, and they only leave very small intercellular clefts. So in between the snaps, there's a little space where things can leak in and out. And the things that can leak in and out are very small. They're not cellular. And our notes here say for simple diffusion purposes, so I'm talking about sodium, potassium, chloride, glucose, things like that. Very small molecules. We find continuous capillaries in the blood vessels related to our skin, in our skeletal muscles, in our lungs, and also in our brain. That's where we find those guys. The fenestrated capillaries appear to have pores or windows on them, and they allow for movement actually of now a little bit more material. We can actually move small proteins across. So amino acids, things along that line can actually move across these fenestrated capillaries. And they are considered more leaky than our continuous capillaries because more can actually move across. They are found in areas of high absorption and filtration, and the intestinal tract is an area of high absorption, and the kidneys are indeed areas of high filtration. And so these fenestrated capillaries are very rich in those areas. They have the same basic structure as our continuous capillaries, except for these holes that are covered by an extremely thin membrane. and it's what allows for more material to actually pass through this thin covering. Sinusoidal capillaries, as our notes state, are discontinuous, so they're wholly. And they are this way because we want to move large substances through them. And let me give you an example of where we find sinusoidal capillaries. Bone marrow, liver, and spleen are organs that actually have the sinusoidal capillaries. Remember, bone marrow, what we like about that is it makes the cellular elements of our blood. So in order to get those elements into the bloodstream, we have these nice sinusoidal capillaries that will allow cellular elements to actually pass through. And that's why we have large substances, formed elements can pass through. Or you can say leak, but we want to actually have them pass through and be put or removed from bloodstream. So the fenestrated still has those tight junctions, but it has these little spots. Take a look at that picture, a cartoon picture of the fenestrated capillary in the middle. It looks like it has chicken pox, something along that line. It has these spots, and those are the pseudo holes that we just have a very thin membrane covering that and allows things to move from the bloodstream out into the surrounding tissues. Continuous capillary, just a small amount of material actually can leak out because of the very small intercellular clefts. So least permeable, continuous, most permeable, indeed, sinusoidal. The capillary beds will supply, say, muscles, organs, things along that line, will actually have a sphincter called a pre-capillary sphincter that is going to be in charge of the flow to the capillary bed. And let's take a look here. Here is an arteriole, and it's giving rise to a capillary bed, so it says true capillaries in the middle. And then on the other side, we'll get to the venous system, and we'll actually find a venule that venous blood will empty into. And the coloration here is good. Red's for oxygenated, and blue is for deoxygenated type of blood. And we see right here and here and here and here these little precapillary sphincters. When they contract, that will not allow the blood to go into the capillary bed. It will force the blood through this thoroughfare channel right back into the venous system. It's like a bypass. And the reason we do this is that sometimes we need to actually regulate the blood flow to an organ, because we're actually going to learn that whenever, like say, your quads are being perfused, one of the things, you guys know what your quads are, right? Ventral, just checking. Ventral thigh. It's been a few months since last semester. Ventral thigh, okay? So when your quads are being perfused, they're not being 100% perfused. What's happening is various capillary beds to the muscles are nice and open and sending them the blood, and others are constricted. And then that nice open one will close on down, says, I fed you enough, I'm going to cut you off now, and I'm going to send it out to our companion tissues. And so we have this lovely system that will regulate the amount of perfusion or blood flow to a tissue to make sure that everybody's getting their equal share. And so these precapillary sphincters are very helpful for that. The thoroughfare channel indeed is that shunt that will bypass the capillary bed at that time. But when the tissues say, I need oxygen or else I'm going to undergo necrosis, those precapillary sphincters will open up. And necrosis means cell death. The venous system, when you compare the walls of veins to arteries, they are indeed thin, and I like to use the word flabby. The first structure that is venous that you will encounter after a capillary bed is called the venules. Smallest of the veins and typically companions to the arterioles. So where you find arterioles, you'll find venules and vice versa. And indeed, these are so small that you cannot ordinarily see them, and so therefore are not ordinarily named. But the venules will give rise to larger vascular structures called veins, and they'll have a nice large lumen, and the lumen indeed will be larger than arteries. And we're going to learn in just a minute that the pressure which moves blood through this system is actually quite low. And so in order to prevent backflow in our veins, we actually have valves. We have valves to prevent backflow of blood in our heart, correct? And so our veins have valves to prevent backflow of blood in our veins. This is not something that's in the arterial system. It's only in the venous system. And this will ensure blood flow in one direction in the venous system. And these valves are just like these semilunar valves. And so there's these pockets that will encircle the inner circumference of the lumen to ensure that things don't move in the opposite direction. The thing about veins, they are low pressure systems, so can only withstand low pressure. The valves, of course, prevent backflow. Tunica media, some smooth muscle, but it's mostly tunica externa. That is the heaviest. Our venous system, the venous component of our vascular tree, is a blood reservoir. We have at least 55% of our blood volume in the venous system. So the bulk of our blood is actually on the venous side. And so if we are under a lot of turmoil, fight, flight, we will actually have, it's one of the reasons why we have muscle in those walls. Those veins will be able to actually vasoconstrict and push the blood back into the arterial system to send oxygen to the tissues that are in demand for us. Vascular anastomosis. Okay, so the vascular tree has additional branches or additional pathways through, to, or from an area. So blood supply to your hand. You already know the name of two vessels that supply blood to your hand. Radial artery, ulnar artery. So we have two blood vessels already going to your hand to supply blood to your hand. They also supply blood to your forearm, but more importantly, they're sending arterial blood to your hand. What's really fascinating about these two vessels is as they come distally towards the palm of the hand, they will divide and create a superficial palmar arch and a deep palmar arch. So in other words, the radial and ulnar artery, which branched from the brachial artery going down to your hand, will come back together again in your hand in a superficial as well as deep palmar arch to supply circulation to the palm of your hand as well as give rise to what are called your digital arteries. You guys figure out what I mean by digital arteries. So that's fascinating. You have two ways for vascular supply to your hand. And a cardiothoracic surgeon knows about this. A cardiothoracic surgeon is somebody who will perform surgery on your heart, especially if you have a blockage that cannot be treated with stenting. They will do bypass. So a bypass requires that we find a vessel. We got a blockage. We find a vessel. We will open up that vessel. We'll harvest it. We'll take that vessel. We'll plug it into the area right before the blockage, and then we will plug it into the area right after the blockage. So that blockage doesn't matter anymore because we have bypassed it. Well, what they can do, the cardiothoracic surgeon can do, is they can harvest a vein from your leg called the great saphenous vein, because we got tons more veins than we do arteries. But if you don't have a good saphenous vein, they will go to your forearm and they will take out, more often than not, your radial artery. They will take a nice big chunk of your radial artery out of your arm and they will put it on your heart. And your hand will never know the difference because you have more than one blood supply, arterial blood supply, going to supply the hand. We call those additional branches collaterals, but the collaterals typically have names. This is very important because if one became clogged, you don't want to actually have then death of things downstream. The other blood vessel will take care of that. Let's go to the venous system next, because this one has really lots and lots of anastomoses. That's why we say here, very extensive return system. It is so rare to block this system back because there's so many ways back to the heart with the venous blood. For example, when somebody undergoes a deep vein thrombosis, do you guys know where that deep vein thrombosis typically occurs? In your leg. And it's deep. That's why it's called deep vein. It's the veins deep in your leg. And so you never see them. You never even feel that you have this vein that's filling up with clots, which will solidify for you. So this vessel is filling up with clots. You're never aware of that because you have so many anastomoses bringing blood back. And so we like to refer to this venous system because there's so many additional ways for that venous blood to get back. If you find two veins in the same area and you have a name for one and you don't know what to name the other one is typically called the accessory. So you don't know you have a deep vein thrombosis until you end up with symptoms, what I call downstream, which end up actually at your lung area. But you have no idea that you're not getting venous return properly from that leg because you have so many additional veins bringing blood back from that leg. Externally, the one that I was just talking about earlier that you should become very familiar with is the great saphenous vein. It starts on your foot, on the medial aspect of the foot, right by the medial malleolus. It's that little blue bulge that you see anterior to your ankle. That's the great saphenous vein. It comes up your leg. It's actually the longest vein in your body. Comes up your leg, goes a little bit behind the medial aspect of the knee, then comes back into the medial aspect of the thigh and empties into the femoral vein, which, as you guys probably do know, is right in the groin area. So the great saphenous vein can be taken out for harvesting. It can also be removed for varicosities. You guys know what varicose veins are, right? So varicosities are related to incompetent semilunar valves. And so we get stretching and then we get clotting and we get pain and stuff like that and that. But you can take out the great saphenous vein for harvesting, for bypass surgery. You can remove it for varicosities because you have deeper veins and you even have other superficial veins that run up the back of your calf. And if you've seen somebody that's a very athletic runner and stuff like that, that nice blue vein running up the back of their calf is their small saphenous vein. which happens to start on the lateral side of the foot and goes around the lateral malleolus up the back of the leg and empties into the popliteal vein. When I say these things, popliteal vein, do you already have a picture of where I am talking about in your mind? That's what learning what all these words mean. You then actually know what I'm talking about when I say a vascular structure in a certain area. So lots of ways back. An example too on the human cadaver, when we are in this area of the arm, what would we call an artery in this area? You guys, brachial artery. The brachial artery is going out. Right next to it is a brachial vein, but then also a little bit over is another vein that looks just like the brachial vein that's right next to the brachial artery. And we call that vein, because the students always ask me, well, what do we call it? Well, we call it an accessory brachial vein. So there's just so many ways to get the blood back. And so many veins superficially. Do we have arteries superficially? No, we only have arteries that you can feel close to the surface in very few areas, for which we actually are able to then record pulses. One more vascular anastomosis, we kind of talked about it earlier, is the arterial venous, which means that we're an artery and we are not going to be a capillary bed, we are going to be a thoroughfare channel, and we are going to then connect an artery to a vein. More specifically, a smaller structure, an arteriole to a vein. That is not common. That is actually uncommon. There's very few places that we actually have that type of anastomosis. We will surgically create this type of anastomosis with an artery and a vein for somebody that's undergoing hemodialysis. The reason people undergo hemodialysis is because they have kidney failure. Their kidneys are not working. The fascinating thing about people that have the arterial venous shunt is that whenever you actually feel it, it actually vibrates. It's so close to the surface you can actually feel the vibration of the valvular system as the blood is forcefully pushed throughout that system. Do you think people get their blood pressure taken on that side? No, absolutely not. So people who have these type of things, it's very specific and will interfere with regular assessments of their overall circulatory tree. Let's go into circulation now. We talked about all kinds of things about blood vessels. Now let's talk about blood flow in the blood vessels. Blood flow, volume of blood flowing through any area. It's kind of self-evident, but we also have another name for that, and that's called perfusion. Because they can say you have good perfusion or you have poor perfusion. Good perfusion means you are nice and pink. Poor perfusion means you look pretty white and pale. So that's telling you the amount of blood flow through the area is high when good perfusion and low with poor perfusion. So those are just some terms that are commonly used out there in the medical field. Blood pressure. Well, what is blood pressure? Blood pressure is the actual force exerted or felt by the inner walls of the blood vessel expressed in millimeters of mercury. And the blood vessels that we are talking about are the arterial side whenever we do our blood pressures. We're interested in the arterial pressure because arterial pressure tells you everything about perfusion, doesn't it? Because if somebody has a blood pressure of 120 over 80, what do you think about their perfusion of their tissues probably? Good. What about 60 over 20? Not good. So blood pressure is very important. It has a direct relationship to tissue perfusion, which is also talking about perfusion of various capillary beds. Some other terms that are very important in our discussion about blood pressure and blood flow is this term called peripheral resistance. And I want you to realize, whenever you hear the word peripheral resistance, realize we're slowing down blood flow. Whatever it is, this mechanism slows blood flow down. Viscosity, thickness of a fluid, will slow the movement of that fluid down. Is that something easy for us to regulate, the thickness of our blood? No, that's not something that we can regulate within a minute or two. So viscosity is not a mechanism by which we actually will control blood flow, but it is going to have impact on blood flow. And the only time that you would probably experience a viscosity related issue is if you're a Sherpa. You guys know what Sherpas are? They live at very high altitudes. And why would I say that their blood might be thicker than yours? Definitely more red blood cells, right? And the more red blood cells you pack into this fluid of ours, it is going to increase its viscosity or its thickness. So, but that takes a long time for that to actually occur. So viscosity is not going to be something our body typically will try to regulate to affect blood flow. But we do know if you increase your viscosity, you will decrease flow. So it's important that we talk about this. And if you decrease flow, this is synonymous with increasing peripheral resistance. Vessel length. What will vessel length? The longer the vessel that you have, what will happen to the flow of blood in one end and out the other? Will it be the same rate? No. And that's because of friction, right? The friction of the longer walls will actually start to slow down our blood flow. So vessel length will cause decreased flow or increase in peripheral resistance. So increasing vessel length will gradually decrease flow, which is synonymous with increasing peripheral resistance. I knew my speller was off. It's not easy to regulate vessel length, but it does tell you that the flow of blood closer to the heart is faster than the flow of blood further on down my arm and forearm, correct? Vessel diameter, that's the one that we can more easily regulate. So that's whether we vasoconstrict, which makes a smaller vessel diameter, or vasodilate, that will directly impact the amount of blood that we can actually have flowing in. Smaller diameter, so decrease our diameter, will decrease flow, and therefore we refer to that as increasing our peripheral resistance, PR. One of the things too to realize about decreasing the diameter of a blood vessel close to the end or at the end of a nice long tube, we have a vasoconstriction going on. What happens to the pressure upstream? That will actually increase the pressure, will it not? So this will have a great impact also on our blood pressure. Systolic and diastolic blood pressure is referring to the ventricular phenomenon because we're in the arterial system. And systolic blood pressure occurs during ventricular systole. And this is all about blood moving into the arterial system. What's an average systolic blood pressure that most people consider reasonable? Good. 120. And we're going to stick with that. 120 millimeters of mercury. Our 120 is actually kind of high because of our lifestyle. If you actually go to a country that does not have our type of lifestyle and has a high fiber diet, not a lot of animal fats and proteins and things in it, they actually will have a blood pressure systolic of around 90 to 100. So our 120 is what we call normal for us, for Americans. So that's a good blood pressure if you're an American. Diastolic blood pressure is going to occur during diastole. And one of the things that we know during diastole, semilunars are closed. So in other words, we don't have blood moving into the arterial system, but we actually have residual blood in the system moving along because of the elastic recoil of the vessel that they just were forced into. Not but, and still moving. Average American diastolic blood pressure that's still considered to be healthy is 80 millimeters of mercury. So in systole, we get a big bolus of blood into our aorta. It expands, so that means pressure's up, correct? In order for it to expand like that, pressure is up. Now we close our semilunars, and we know that the blood wants to fall back into the heart, and that's why the semilunars close, correct? But because now we can't go back into the heart, we've expanded, we still have to go someplace, right? Because we're going to recoil, and that's going to push the blood down the arterial system. And so the arterial flow is not start, stop, start, stop, start, stop. It's whoosh, whoosh. It has a nice waveform phenomenon, and you can appreciate the waveform flow of our blood because you can actually feel somebody's pulse. And the reason you feel that is when you don't feel a pulse, you're feeling diastole, and when you feel a pulse, you're feeling systole. And so that's why we call that pulse pressure. Pulse pressure is systolic pressure, which would be around 120, minus diastolic pressure, which would end up making it around 40. We will go ahead and talk more about how we use pulse pressure to measure a speed parameter called mean arterial pressure through the arterial system next time.